It's much easier to see where the flaws are and correct them than in a much larger hospital. And sometimes it is just being a much smaller place, you can identify where the leaks are and work on them than when you're such a big unit.
Welcome to Health Chat, the UK's #1 health and social care podcast. We discuss the most important issues in the healthcare sector and the challenges our colleagues face from the front line of delivery to decision-making in the boardroom. Join me, your host, Dr Atif Ghaffar, as we speak with interesting people from across health and social care and bring you expert insight and discussion on the topics that matter most to healthcare professionals. Hello everyone, welcome to the latest episode of Health Chat. I'm Dr Ghaffar, the Medical Director at Health Group. Today I'm at the Chamberlain Clinic in Harborne and I'm with its Clinical Director, Dr Rupal Morjaria. Dr Rupal is an accomplished eye surgeon and together with her husband, she founded this extraordinary clinic in the heart of Birmingham. Rupal, thank you very much for joining me today.
Thank you for inviting me. So it's a pleasure to have you here.
Thank you very much indeed. Now, I've been to the clinic before. I think we met probably a few months ago. The clinic's located in a beautiful part of Birmingham, Harborne, Edgbaston, and the reception is very inviting and you've got extraordinary artwork. You've really put your heart and soul into developing this clinic. I'd really love to know the history of how you accomplished this and some of the challenges along the way.
So let's talk about challenges last, shall we? So the history of how we got to this place is my husband and I were looking for places to have some private practice. So essentially I set up a national rare disease clinic in the NHS and patients just couldn't get hold of me. So there was a 2-year wait by the time I left the NHS. And there was some sort of emergency. No matter how hard we try as clinicians, sometimes you cannot see your patients in time. So even though we heavily believed in providing care in the National Health Service, there is a certain amount of speed that does help patient outcomes. So in that process, having been looking around for consulting rooms, I actually had some of my old mentors who used to consult in this building, particularly downstairs. So that's how I started, just seeing an occasional patient once a month. And then it came about that a close family member of mine, my brother, actually said to me, Rupal, why don't you set up the consulting rooms? The owner is looking to retire. So it was my brother's idea, who's a businessman and an optometrist by background. But it all came, and I took it on as a challenge. I've always wanted challenges. I'd finished my research, having done a PhD. I'd had my children. I was in a nice NHS post, so I wanted another challenge. And from a small hobby, this became my big project. So I think it's developed quite naturally, and I've really enjoyed seeing it evolve. At first, the building, needed a lot of renovation, so it was the aesthetic appearance. But now I'm really focusing on the clinical work we do here and providing a really good standard of clinicians and good quality care for the patients to try and stop blindness, stop, health problems getting so bad before they are seen with the long waiting times that we currently see in the NHS.
Mm-hmm. Now, your specialism is ophthalmology. What sort of treatments do you offer here that were difficult to offer on the NHS, or sort of procedures that you just couldn't get done in time or to the satisfaction of your patients?
So I'm a retinal specialist and I specialise in diabetic retinopathy, macular degeneration. So these patients lose sight very quickly or suddenly. And even when I see these patients at other units or the NHS, there's meant to be a 2-week referral time for urgent retinal problems. This can be several months, and in some trusts in Birmingham, it's over a year for wet macular degeneration, which is sight-threatening and scars up the retina. Once the retina is scarred up, you can't save the sight. And then once a patient is seen in clinic, you list for the treatment, and that can take another couple of weeks. Here at Chamberlain, if I saw someone with leakage at the back of the eye, I would be able to see them, scan them, and inject them on the same day or the next day if they want 24 hours to think about it. So it's that speed that leads to much better outcomes, and I'm finding the more and more we have doctors here, that's what they're taking on. We have some of the best vascular surgeons in this unit who again provide vascular treatments, general practitioners, and a lot of times the disease and the chronicity isn't as a result of the patient, it's just the delay in diagnosis and delay in treatment which we are trying to help.
You've mentioned delays in treatments and diagnostics and access, and unfortunately we're seeing that in so many departments, particularly post-COVID. How does a private service like yours complement the services in the NHS? Because some people in the public, a lot of patients think that it's either NHS or private and the treatments are entirely different. But in fact, the reality can be quite different. Could you explain that? Yes,
so there's a number of aspects of this. It's a treatment offered, whether it would complement the NHS. And secondly, you're right, I do have a lot of patients saying, I can't afford it anymore. Would you mind if I went to the NHS? Would you still see me in between? So there is a cost of living crisis. And in the past, I used to have colleagues, my supervisors, people who trained me, who had a very healthy private practice. They would see patients again and again. However, now there is a price limit. People can't afford private healthcare. However, if there's an emergency and they're losing sight or they need urgent scans, they can afford to see a specialist urgently and receive some treatment urgently to avoid loss of sight, for example. And often I have patients, and I understand how expensive these treatments are, even if we try and be as cost effective as possible, not everyone can afford them. So I also say to patients, where are you from? Would you like me to refer you back to the NHS? So what services like ours offer is for patients to receive treatment while they're waiting for their NHS appointments. And I also coordinate with their specialists if I know them. There's been times when I have seen patients and provided an expert treatment plan. And in fact, I've got a few people from out of region who couldn't see the NHS services. I saw them, provided a treatment plan, emailed it across to their department, which meant the care was expedited. And rather than then waiting for another consultation, as those colleagues knew me, that went on straight away to have injections in the NHS. So I do that. There's some patients who want to have NHS care because of the cost, yet they want, they don't want to wait. That 6 months becomes 8 or 12 months because of the waits and the cancellations, and they want to see a specialist in between. So they come and see me at 4 months, 6 months, just to make sure things are okay till the NHS treatment comes through. Because it's the treatments that sometimes are more expensive. And then there's others who have 3 or 4 treatments that's kept their vision going until they're seen. So there's lots of ways how we can work with the NHS. I do say to the patients, it's not like it used to be, we can work together. And for me, we've taken an oath. It is for the best interest of the patients. The other things we are better at is if treatments are NICE approved or have been, they're new, but the local trusts or local ICBs have not yet approved them. If we know they're NICE approved, they're safe, they work well, there's good safety criteria, then these treatments we can approve. So sometimes some trusts are limited by what drug they give. So for example, with the retina, there's lots of injections called anti-VEGF injections. Some use something called biosimilars, which are the newer drugs, which are more cost effective for the NHS. And then there's others, such as a drug called faricimab, which is a dual compound, and we know it works very well, but it's much more expensive. In the private practice, we're not limited to what the local trust needs. We can base our judgment on what will be the best for that condition. And then they can always switch back in the NHS. So patients have a little bit of, it's a joint approach and a joint decision making rather than being limited by a set of rules.
So I guess you're offering them more autonomy or certainly options.
Exactly.
Now, for patients who are insured or self-paying, they probably find your services online. Do you think more can be done by GPs in primary care to explain to patients what other options there are at a time of such crises where time is of the essence? Do you think more can be done to explain to patients these are not just your only options? There's a great clinic up the road that could probably help you, and why don't you go and find out?
I think so. I think this is a big debate currently under medical practice. So there's lots of countries like Australia where there's dual care, there's government and private hospitals, sometimes in the same hospital. And even now, in Edgbaston in Birmingham, some of the NHS hospitals are building private wings because I think people are finding it is more compatible. For example, we do a lot of cataract surgery. In the NHS, a lot of trusts just provide you one type of lens that's called a monofocal lens that can only allow you to see clearly at set distance. If you have an astigmatism, some trusts don't even provide that lens. However, now there are newer lenses that allow you to see clearly for distance or near, or give you an extended range. The NHS hospitals, 98% don't even offer these options or don't even discuss them. If you're having surgery, wouldn't you want to know that I'm having this standard lens, but actually I could have a lens that allows me to see clearly for distance and near. These are the risks, these are the benefits. I now tell patients, this is the standard monofocal lens. It will give you good vision for distance, or we can set it for near. But for other distances, you'll need glasses. However, now there are different range of lenses available if you wish to. However, they're available privately. I think because of the way we were as doctors, we didn't tell them about the private options. We are limiting the patient choice and we are taking away that autonomy. And I don't think there's anything wrong with telling patients, yes, I can refer you, it will take you 12 weeks, 16 weeks, but there are these options available if you go privately. And you're not pushing, you're not selling, you're actually advising the patient and for them to make a decision knowing the risks and benefits and choices.
I think you've touched on something there where health perhaps is maybe seen as a commodity nowadays, and that people should invest in their own health. And as consumers, we probably spend a fortune on lots of things, whether it's a mobile phone subscription or TV subscription or food choices and things like that. And I think as long as everyone has the information to hand, patients should be given the most relevant information, the most up-to-date information, so they can actually be involved in the decision-making process. Now, in your clinic, apart from the ophthalmology services and vascular surgery, I know that you're inviting other practitioners to come and you're opening a whole sort of complementary range of other services. Could you just outline what some of those services are and why they're coming here? What's the vision in terms of a holistic approach to health and well-being?
So we are really trying to just not make it about clinical care because, for you to have a clinical condition, there are pre-existing things that you can adapt, whether it be diet, obesity, diabetes. So I have been meeting with a lot more specialists. We've always had a fantastic podiatrist here. We've had another podiatrist join who really doesn't just do a pedicure, doesn't do podiatry. She looks at your health. So if you do a specialist diabetic foot checks, doesn't want the patient to have gangrene, but, looks at foot health, looks at their posture, tries to avoid things before it gets so bad. Things like weight loss, it's a big crisis. And there's lots of clinics offering injectable treatments. However, what happens when the patients lose weight on injection treatments and then when they stop the treatment, go back to the same diet? So we've got a fantastic health coach here who will see patients, talk to them about lifestyle, not just diet, but the whole lifestyle, what they do day to day, how they can change their daily habits. So if our doctor does prescribe an injectable treatment for weight loss, that's complemented with the lifestyle coach. And in this way, I am meeting lots of other doctors and specialists doing complementary medicine, whether it's acupuncture, psychotherapy, because I'm really keen on getting these other doctors and non-medical specialities in, so we can all work together collaboratively, with our general practitioners, with our orthopedic surgeons, because we all need help to work together to reduce the amount of morbidity we see.
Now, you said you'd touch on the challenges later on. You've got a fantastic setup here, but we all know how difficult it is in financial terms, the time it takes, the amount of regulation and scrutiny that we come under as practitioners, particularly when we're setting up private services. So along those lines, how was your interaction and discussions with the CQC, getting infection control and all of these sort of things? Can you run through that process with me?
So as the whole process, I've had to become from a medic to a business lady to an infection control nurse to a manager, even a receptionist, at times. I've done every aspect of this job so that I can know how the business runs and I know where the errors are. So firstly, we had to hire a great team and someone who would support us and make sure everything is done in a proper way. All our doctors we had also had to be part of the process with similar thoughts. CQC process, we had to change lots of things in the building to make sure we're CQC compliant. The room flooring throughout the corridor and the newly refurbished bit is the CQC compliant flooring. The rooms downstairs, first of all, when I started doing my eye procedures, they had to be changed to make a CQC compliant room, and then have all the procedures and policies in place. So I'm lucky that I already had colleagues working in this clinic who had CQC who helped me to find out how I could go about these processes. And then regular audits and checking, those are mandatory. Having worked in the NHS in clinical settings, I'm aware of what happens to happen. And then I have a good management team, HCAs, who day to day do all the checks.
And would you say having an awareness of what needs doing or understanding the culture of regulation and compliance has assisted you in getting the clinic up and running? I
think as doctors, we're quite lucky that we let's say grow up with rules from training days, from being a first year medical student and going to hospitals. We're used to being told the minute you get into a ward, clean your hands with alcohol gel, use the different bins. This is a sharps box. So we've done it day to day without even knowing what we're doing. We've had to do all our mandatory training for our appraisals for years on end. So for someone new, when you hire a manager, this is all a learning process. But when a medical person takes over a clinic and is trying to grow a facility, if you did the same, you would know a lot of this from your clinical experience. But then it's actioning it and keeping it in place, which is when you have to train the day-to-day team to make sure that's done.
And along the way, how supportive or how engaging were the CQC from day one throughout this entire process?
So we applied for CQC last year. We had our first, it was done over Zoom, so waiting for a visit. And I was new to this. I showed them the building, told them what we wanted to do. The initial proposal didn't have certain services and they were very good at talking us through it. We initially wanted to have a hair transplant service and a clean room. And then we were looking at having children of a certain age. So they were actually very helpful. So I spoke to them what I wanted. They said, actually, on your statement, you need to edit this, you need to have this in this way. So following that, we've changed a lot in the rooms. And actually, I found them very helpful in telling us what we needed to be doing.
So I'm glad to know that you've had a very supportive experience with the CQC, and that's quite reassuring. I'm sure to a lot of our listeners and people viewing the podcast, that would come as a comfort. I think for clinicians like yourself who want to make the bold move, who want to provide services that are not available on the NHS for the benefit of their patients, if they're watching this and they want further encouragement, what would you say in these times? Is this a huge risk and a huge undertaking that's going to cause an immense amount of pressure and stress, or should they be bold and get the right help with agencies like ourselves or others to make that move?
I think I've had actually a few ophthalmologists, colleagues of mine from London, ask me how I did it. And it really helps if you do it with a few people, and they have got in touch with me to see how I do. It's helpful if you're not doing it on your own. So even if it's an ophthalmologist, a GP, an ENT surgeon, a few specialities that sort of fit together, that have a similar idea, and you do it together, then you share the workload, you share, you share the cost, the ideas, everything. It just works out a lot easier than doing it on your own. I know you say the Chamberlain Clinic, I'm the director and the founder. However, I was lucky, this was previously owned by one of our well-known orthopaedic surgeons, and we had the vascular team, who are the leading vascular surgeons in Birmingham, already set up, and they had their own CQC, and we've got a fantastic fertility doctor here. So both of those were my mentors in setting up our own CQC. You can have people who do a lot of the CQC heavy lifting for you, the protocols, paperwork. So I use that service, and they actually showed me, look, Rupal, this is how we've done our room, copy the rooms, because you need to set floor, set taps, set walls. And once someone shows you the ropes, it's much easier than trying to reinvent the wheel, which is, and you remember I've spoken to you, we've met before, and just, right, this is the mistake I think a lot of people have. This is Edgbaston, there's lots of clinics here, and a lot of clinics are isolated, don't want to work with others. Yet if you do work with others, make friends, you'll learn a lot more and you'll benefit a lot more. We've got clinics on every side of us, and I collaborate. There's some patients I send somewhere else. Opposite, they send me patients back, because you can't be an expert in everything. And so actually now, they will send me things that I specialise in, and I'll send them some things. Rather than, there's no point all of us in a square area, 0.5 mile radius, having every single piece of equipment. You can have the best care for your patients by working collaboratively with your colleagues in the area. And I think that's really helped me turn this place around quickly and provide the care I do for my patients.
Another thing that you touched upon is getting the right team around you and have the right experts to assist you in delivering everything. And you're busy doing the surgery, your colleagues are busy delivering their specialty care, and then you appoint a manager to sort of hold everything together, and the receptionist and cleaning staff. When it comes to upholding those policies and procedures and keeping up to date, we've developed a software called Health Manage, and there's lots of software tools available, but particularly with advancing technology and the amount of complexity of the things that you offer here, how valuable are these sort of tools in making sure that everything's up to date and you've got all the right documents and things prior to your upcoming inspection?
No, it is very valuable to have these document software, because a lot of places you should do things manually. So check every single doctor's appraisal up to date manually, checking, all the things are done. But having software systems in place, and since we've had ours, everything's so much more streamlined, and there's softwares where the letters can go automatically, the reminders can go out, the payments can come in, anything that's missing gets alerted, flashed up. And you're right, software systems can be difficult to get used to, and not many software systems are perfect, but they do reduce the workload substantially. So I think we are becoming an AI-developed world, robotised world, and I think we need to take advantage of it and not fear it.
Mm-hmm. Now, there's a bit of a political type question, and I like to ask this of my guests. The NHS is going through crisis. Politicians and lawmakers and policymakers have all unanimously said it needs to go through reform. Over the next 5 to 10 years, I'm not saying come up with all the solutions immediately, but you must have had various thoughts. What could we be doing collectively as a government, as clinicians, as healthcare professionals, administration staff, managers? What could we be doing to just fix some of the things wrong with the NHS at the moment?
So I have recently come out of the NHS only a month ago, and I think I can see a lot of the difficulties and advantages of the NHS. I also work for an independent sector hospital where we deliver NHS surgeries in a private hospital. essentially, for example, in the NHS, when I have a cataract theatre list, so the cataract operation takes 10 to 20 minutes, they used to struggle to get 5 done in a 4-hour slot. And at the independent sector, we do 12 comfortably in a 4-hour slot. I'm the same surgeon. It's not that I'm operating faster, it's the efficiency. And the paperwork is the same. CQC, with always that trust is always ranked very highly, 5 stars. So it's not like we're letting anything pass, it's just the efficiency. I think morale is a big issue in the NHS. You know, you have managers, nursing staff, medical staff, there's a big disconnect. After years, there is a low morale because it's very difficult to change things, and then people do lose morale and they think, well, they may feel I'm getting paid for being here regardless. There's no push, there's no drive to bring the patients through quickly. The care, the complexity of cases is fantastic that we deliver. And, the subspecialties and the knowledge base is excellent. It's the same doctors, same nurses provide both care. However, I think a lot of it comes down to the morale, the cost constraints. So before my transition to going private, I was working in the NHS and the private sector. Yet I quickly noticed that some of my private hospitals were getting the newest lasers. I've got the best scanning machine downstairs for the eyes. I can just go down and scan it myself. Anyone can, rather than one of the old-fashioned ones that's manually done. So I think the NHS is so big, they've got limitations in where they can put their finances, and some departments do lose, and that as a result leads to all these difficulties and low morale and delays. If they did do 12 cataracts a morning, can you imagine how low the waiting list would be?
Any solutions to fix any of those things that come to mind?
I think that's much bigger than me. So unfortunately, no, I think it's not just having a cash injection. I think the whole infrastructure has to change. There's lots of difficulties with the way some people feel they're perceived to be treated. You have the horses in the NHS who work really hard, and then there's always the bottlenecks. But in the smaller units, it's much easier to see where the flaws are and correct them than in a much larger hospital. And sometimes it is just being a much smaller place, you can identify where the leaks are and work on them than when you're such a big unit.
So a question that came to mind, rather than discussing patient demand, it's sometimes an old-fashioned term, let's talk about in private care, where patients, obviously they want to know what's available, but how do we make treatment more bespoke according to either what the patient wants or what they've heard of or what's in their best interests?
It's so lovely that you asked this question, because actually it's something that I'm really love to deliver personalised care. So I'm passionate about it. So I mentioned it previously, but let me mention it again now. So and I tell my patients, it's like having a suit or a dress made for yourself, tailored, or if you pick one up from the high street, it might still look nice, but you notice the cut when it's been personalised. And you feel better, it'll fit better, it'll last longer. And it's the same with personalised medical care. I touched on cataract surgery and the lens options. So in the NHS, if you were to have cataract is when the lens in your eye is cloudy. It can happen with age, most likely, and sometimes earlier if you've got other medical conditions. You remove your lens, you put another lens in. Most of the time people aim to see clearly at distance, and so you would get that. You still need to wear plus lenses, so bifocals, reading glasses for close up. But now there's trifocal lenses, extended depth of vision lenses, toric lenses, all of these. And you can't deliver this in the NHS. If you came to me as a friend and said, what do you recommend? By going privately, you could have a made-to-measure lens for your eye. So we do, first of all, we need a lot more measurements. We plug all the numbers, the length of the front of the eye, the length of the white of the eye, all the measurements of your individual eye onto a system to order the correct lens for you. Again, there's lots of lenses. It's like choosing breakfast cereal. There's many lenses, and depending on the condition of your eye, the risks and benefits, you would choose one that's perfect for you, and you can order it. So this is something that allows you to personalise it. Other things, again, basing on ophthalmology, being an ophthalmologist, you have a lot of hospitals in the NHS, they have a treat and extend system. So with the eye injections, all the trials show a lot of injections work best. You give them 3 every month, and then every 6 weeks or every 8 weeks, but some patients don't need them every 8 weeks. They may need them every 16 weeks or 15 weeks. And some patients may need 4, and that's it. Most NHS pathways would be a fixed rolling rota, and then you're seen at set time periods. And that's only because that's how it's managed. It's managed very well, particularly at my previous trust. It was done excellently. However, with the private practice, a patient could come and see me. I had the patient this morning, came to see me saying whether they needed an injection. They didn't. When the eye flares up, I would inject them, and then I don't have to stick to those guidelines. I can give them an injection slightly earlier or slightly later. They may need it every 5 weeks or every 9 weeks. It doesn't tick a set box. And this gives patients better outcomes. So, and I think patients feel this. So I do work very closely with referring patients back to their NHS centre because cost is an issue. However, I've had quite a few come back because they don't get that personalised approach. And it's not always about the treatment I'm offering. It's also about me knowing the patient, getting to know where they live, their hobbies, speaking to them. I can spend an hour with a patient if I want to, and they develops the rapport, develops the trust. And I'm not spending an hour with them for the financial benefit because it's not a cost per hour. It's to really get to know my patient, because then you sort of get to know what they would want to do. Sometimes there is a grey zone with treatment, and you will know that as a GP. Some patients will always want to do maximal amount of treatment, and some people sit on the fence, and there's no right or wrong answer. So by getting to know your patient, you get to know what they'd prefer, whether you go for the slightly more holistic approach or treat it conservatively or go for the most aggressive treatment. And I think this is why I enjoy private practice, because I can deliver that care and I can give my patients as much time as they need. If they need multiple consultations before they decide, I will even ring them up to speak to them, see how they're doing, which is something I just wasn't able to do in the past.
Thank you very much for your insight. Rupal, you've been a wonderful guest. Congratulations on the opening of the clinic, on its expansion, on all the services that you're offering, and we wish you all the very best in the future.
Oh, thank you for having me on your show. Thanks.
So thank you very much for watching. That's the end of this episode. And if you enjoyed this and you like more, please don't forget to like, subscribe and share. And we'll see you on the next episode. We are the Health Group. We work with the new and existing healthcare providers every single day, from private clinics to adult social care services and NHS trusts, to ensure all providers are compliant with regulations, have a culture of excellence, and are delivering exceptional care.